Acute respiratory distress syndrome ARDS is an respiratory disease. Look at this picture, shows that lungs, alveoli, chest X-ray and CT scan findings. A detail going on. Introduction. Acute respiratory distress syndrome is a severe, life-threatening condition characterized by acute inflammation and diffuse alveolar damage, leading to impaired gas exchange and respiratory failure. Despite advancements in medical care, ARDS continues to pose significant challenges in critical care setting. Etymology. The term acute respiratory distress syndrome originates from the Greek word acutus, meaning sharp or severe, combined with the Latin respirate, meaning to breathe, and syndromes, meaning running together, reflecting its sudden and severe impact on breathing. The term was first coined in the 1960s to describe a constellation of symptoms related to acute lung injury and respiratory failure. Definition. Acute respiratory distress syndrome is a severe condition characterized by sudden inflammation and fluid buildup in the lungs, leading to difficulty in oxygen exchange and respiratory failure. It often occurs as a complication of trauma, infection, or other critical illness requiring immediate medical intervention. Types. 1. Direct ARDS caused by direct injury to the lungs, example pneumonia, aspiration, inhalation injury. 2. Indirect ARDS result from systemic conditions that lead to lung injury, example sepsis, trauma, pancreatitis. Causes. 1. Pneumonia. 2. Sepsis. 3. Aspiration of gastric contents. 4. Trauma. 5. Pulmonary contusion. 6. Inhalation of harmful substances. 7. Near drowning. 8. Acute pancreatitis. 9. Massive blood transfusion. Risk factors. Advanced age, chronic diseases, example diabetes, COPD. 3. Smoking. 4. Alcohol abuse. 5. Genetic predisposition. 6. Severe systemic infections. Complications: 1. Multi-organ failure. 2. Ventilator-associated pneumonia. 3. Barotrauma, example pneumothorax. 4. Pulmonary fibrosis. 5. Cognitive impairments. 6. Physical deconditioning. Pathophysiology. 1. Initial insult or injury. Trigger, mediators. 2. Inflammatory response. Neutrophil activation, endothelial and epithelial damage. 3. Increased permeability of alveolar capillary barrier. Leakage of plasma proteins and fluid. Formation of edema. 4. Formation of hyaline membranes, protein and cell debris. Impairment of gas exchange. 5. Impaired surfactant production. Type 2 alveolar cell damage. Increased lung stiffness. 6. Ventilation perfusion. BQ mismatch. Shunting. Hypoxia. 7. Progression to fibrosis. Proliferative pace. Reduced elasticity. Fibrosis further reduces lung compliance, increasing the work of breathing. 8. Systemic effects. Cytokine storm. The inflammatory mediators can enter systemic circulation, causing multi-organ dysfunction. Acidosis and hypoperfusion. Prolonged hypoxia and acidosis from impaired gas exchange can worsen systemic effects. Management involves supportive care, mechanical ventilation with low tidal volumes, prone positioning, and treating the underlying causes to mitigate progression. Signs and symptoms: 1. Severe dyspnea. 2. Tachypnea. 3. Hypoxia. 4. Cyanosis. 5. Reduced lung compliance. 6. Diffuse bilateral infiltrators on chest imaging. 7. Accessory muscle use during breathing. A diagnosis: 1. Clinical criteria. Berlin definition: acute onset, bilateral infiltrates, and chest X-ray or CT scan. C. PaO2 FiO2 ratio. less than 300 mmHg. 2. Exclusion of cardiac causes of pulmonary edema, example echocardiography. 3. Laboratory and imaging studies to identify underlying causes, example blood cultures, inflammatory markers, bronchoscopy, etc. Nursing diagnosis: 1. Impaired gas exchange. 2. Ineffective airway clearance. 3. Risk for infection. 4. Altered tissue perfusion. 5. Anxiety related to dyspnea and critical illness. Management. First, medical management. 1. Mechanical ventilation. Low tidal volume strategy PEP to prevent elevator collapse. 2. Prone positioning. 3. Fluid management restrictive approach to avoid worsening pulmonary edema. 4. Pharmacological interventions, antibiotics for underlying infections, corticosteroids, controversial in some cases, neuromuscular blockers in severe cases. 5. Extracorporeal membrane oxygenation ECMO in refractory cases. Nursing management. 1. Monitoring respiratory status ABGS, SpO2, respiratory effort to ensure optimal positioning, example prone positioning. 3. Maintain ventilator setting and prevent complications, example VAP bundles. 4. Fluid and electrolyte balance. 5. Emotional and psychological support for the patients and families. Treatment. 1. Oxygen therapy. 2. Ventilatory support, invasive, non-invasive. 3. Pharmacotherapy, example vasopressors, diuretics, antibiotics. 4. ECMO in severe refractory ARDS. Psychosocial medicine. 1. Emotional support and counseling for patients and families. 2. Providing clear and regular communication about the patient's condition. 3. Facilitating family involvement in care decisions. 4. Offering spiritual care as per patient preferences. 5. Encouraging peer support groups for post ARDS recovery. Prevention. 1. Timely treatment of sepsis and infections. 2. Preventing aspiration, example promote feeding techniques, elevating the head of the bed. 3. Avoiding excessive fluid administration in high risk patients. 4. Implementing protective ventilation strategies during surgeries. In conclusion, ARDS is a critical condition with significant morbidity and mortality. Early recognition, multidisciplinary management, and supportive care are crucial for improving outcomes. Preventive strategies and psychosocial support play vital roles in comprehensive care for ARDS patients and their families. Thank you. Have a nice day.